I've been requested to talk about the role of anticoagulants in non-ST elevation MI. I think the anticoagulant of choice for ST elevation MI is already determined, but there is still some controversy about which anticoagulant to be used and what is the rationale for doing that. I think, is there any rationale for starting an anticoagulant in non-ST elevation MI? The answer is yes. When there is a disruption of the plaque, there is activation and aggregation of the platelets, but it also exposes the tissue factor, which creates a sequence of events that leads to thrombus. So there is both activation of platelets and activation of coagulation system. And this calls for not only initiation of antiplatelets, but also initiation of anticoagulants. Administration of anticoagulants certainly decreases the recurrent ischemic events. But along with the combination with antiplatelets, you do get the risk of increasing the bleeding. So we have to strike a balance between what we call a marked decrease in ischemic events and with as less possible of these bleeding events. Do we have any such drugs? And or what is the importance of talking about bleeding? It can be classified as mild, moderate, severe, but it is important to remember that the higher the risk of, the higher the amount of bleeding, the greater is the mortality. There are very many reasons for it. I will not go into the details. So reduction of bleeding by the therapeutics is a endpoint that we all should look at it, because we are using powerful drugs which can increase the bleeding, like combination of antiplatelets and anticoagulants. Now this bleeding not only can occur at the access site, vascular access site, when you are planning to do any procedure, but it can also occur in the non-access site bleeding, including GI tract, intracerebral, and genitourinary tract. Irrespective of the site of the bleeding, it does increase the risk of mortality. The higher the bleeding and the higher the risk of mortality. So we have to make an attempt to, I think when we are trying to compare, we have been, even in the guidelines, we are asked to see whether you can choose an enoxaparin or a fondaparinux. Important to remember that enoxaparin is not only inhibits factor 10, it also inhibits factor 2, whereas pentasaccharide fondaparinux is only selective anti-10 chemical. So, and the duration of action of fondaparinux is for 24 hours, and the duration of action of enoxaparin at the most is 12 hours in patients with normal kidney function. But in patients with deranged kidney function, enoxaparin dosage has to be adjusted according to the GFR. So basically now, is there any trial data by which we say one is better than the other? The answer is yes. It is called a Oasis trial. The initiator again is Dr. Salim Yusuf and company. And a lot of centers in India took part, and our center was one of them. Here is a trial which tried to compare the fondaparinux once a day, 2.5 milligrams, versus enoxaparin, 1 mg per kg, twice daily. And what we found was probably worth noting, that when you compare the ischemic events, both fondaparinux was as good as the enoxaparin. But when you compare the bleeding, the fondaparinux was markedly less, almost 50% decrease in the bleeding events. So here is a drug which is as effective in reducing the vascular events or ischemic events and without increasing much of the bleeding. So it was, when you see that, a cost-effective way, probably this is the best drug when compared to enoxaparin. So now, is there any other study apart from Oasis trial that says that fondaparinux is the drug of choice? The answer is Swedish Heart Registry. And then, okay. I think is not working. This is one of the registry. It's not a randomized trial, but it's a registry, real-world registry done in Sweden, which tried to compare the patients who received fondaparinux versus those who received enoxaparin. And they also found that the risk of bleeding was much less with fondaparinux as compared to enoxaparin. And we did find that there was a marked decrease in the incidence of bleeding. So now, is it comparable that it is used not only for treatment of, medical treatment of acute coronary syndrome with non-ST elevation? Can we use the same drug for intervention like PCI? So they tried to compare fondaparinux with enoxaparin in terms of effectiveness of the drug. Now you can see the data here that fondaparinux decrease in major bleeding was still obvious even at when you are trying to do the PCI. But then there was one marked trouble in that is there was a decrease, but one of the things that really made the fondaparinux not the drug of choice for PCI was the catheter thrombosis or the thrombus within the catheter during invasive procedures was very high compared to enoxaparin. So they said, it was concluded at that time that fondaparinux is good for the medical management of acute coronary syndrome, especially non-ST elevation MI. It is as good and as effective in preventing the ischemic events. But should the patient be taken to the lab for procedures, then you have to add what we call unfractionated heparin. So the question came up, by adding unfractionated heparin, is the risk of bleeding same, more or less compared to enoxaparin? So there were trials, and it did show. One of the trial was the Dayasagar Futura trial. They did try to compare a low-dose heparin, unfractionated heparin versus the high-dose unfractionated heparin in patients who are already receiving fondaparinux during the acute medical therapy. And they did find that low-dose heparin was not good because it did not decrease the events, but no change in the bleeding. So it is concluded now that if you are going to take a patient who was on fondaparinux as a part of medical therapy, if you are taking them for the intervention, you need to add unfractionated heparin for that particular patient. Now the same thing, shown in a different way, but now if you are using the enoxaparin as the drug of choice during the medical therapy, and then you take them to the lab for any intervention, you have got two options. Either you continue enoxaparin or you can change over from enoxaparin to unfractionated heparin. Now this is a very interesting study called Synergy trial, wherein they have shown that if you change over from enoxaparin to unfractionated heparin during the procedure, there is a marked increase in the bleeding. So if you are using enoxaparin as a part of medical therapy, you have to continue only with enoxaparin, additional doses if required, if you are doing a PCI, but don't change over. So what do the recent global guidelines say about the usage of these two drugs? So you can see here that you can use either fondaparinux or enoxaparin for the treatment of non-ST elevation MI, part of medical treatment. But if you are going to use, if you are going to do a PCI, you need to add unfractionated heparin in case of fondaparinux. But then if you are going to use, you see the last one, class 3 is, if you are using low molecular weight heparin, don't use unfractionated heparin during the PCI because it does increase the bleeding and cause more problems. So you have to pursue with low molecular weight heparin only if you are going to do a procedure. So this is one more reason why I feel that fondaparinux should be the drug of choice for non-ST elevation MI. It is as effective as a part of medical therapy, and change over to regular unfractionated heparin during the PCI. Thank you for your attention.